Hello, I'm Abby Olson. I am a movement disorders neurologist at Brigham and Women's Hospital, and I'm happy to talk to you today about movement disorders for this course. I have no disclosures. And here's the outline for the talk. I'm going to start with kind of going over my approach to movement disorders, and then we'll talk about the two major divisions within movement disorders, which are hypokinetic and hyperkinetic movement disorders. And then we'll end with a few board style questions. So I like to start with a definition. So what are movement disorders? So movement disorders are a group of neurologic conditions in which there is either hypo or hyperkinesis. And these definitions are important. We define hypokinesis as a paucity of voluntary movement in the absence of weakness or spasticity, and hyperkinesis as an excess of involuntary movements. If you look at a comprehensive list of movement disorders, the list is long and intimidating, and in my opinion, not actually very helpful as an approach to the field. So instead, I'm going to give you sort of a more practical classification, which is how I think about movement disorders. So on the hypokinetic side, basically you have Parkinson's disease and then a whole lot of other things that look like Parkinson's disease, either because they are secondary Parkinsonism or they are the Parkinson's plus or atypical Parkinson's syndromes. On the hyperkinetic side, the total list of disorders is very, very long, but I think from a practical perspective, if you can recognize what I call the big six, meaning the most common six movements, then that actually takes you a fair bit of the way towards figuring out what's going on. And then I would just add that for 4 out of these 6 movements, the list of potential diagnoses is fairly long and composed mostly of fairly rare diseases. So I think, again, just to reemphasize, the key is recognizing the movement and then referring to an appropriate neurologist. So this brings us to our first case. I'm now going to talk about hypokinetic movement disorders. So case 1 is a 55-year-old woman who presents with shaking of her left arm for the last 2 years. She also complains of pain in her left shoulder and neck and cramping in the fingers on her left hand. The dexterity in her hand is not good. She's having difficulty typing, and she's noticed slowness of her left leg, making it harder to walk. On exam, she has hypophonia, hypomimia, and an intermittent rest tremor of her left hand. There's rigidity in her left arm with cogwheeling at the elbow. And there's also bradykinesia in the left hand and foot. I'm going to show you a video on the next slide. Finally, there is decreased left arm swing when walking, and her postural reflexes are preserved, so her balance is good. So here's a video of this patient.
Okay, go ahead and tap 10 times with your right hand.
So I'm asking her to tap here, starting on the right, and you can see it's pretty normal.
And now with your left.
And now on the left, it starts normal, but very quickly she has what we call decrement.
With your right hand, I want you to open and close 10 times.
So again, here on the right, it's normal.
And then now with your left.
And then on the left, it starts normal, but very quickly becomes slow and small. Now here's another video where you'll see similar findings in her foot.
Can you tap your toe on the right 10 times? And now on the left.
So she's clumsy here, and the movements are small.
Okay, good. Now stomp your foot on the right 10 times. Now on the left.
Okay. So this is bradykinesia, and in particular, it's bradykinesia with decrement, which is a classic finding of Parkinson's disease. So her movements are small, they're slow, and they're also asymmetric, which is a classic finding of idiopathic Parkinson's disease in particular. So that's her diagnosis. She has idiopathic Parkinson's disease. And so I wanted to take this moment to kind of go over the many causes of Parkinsonism, stressing that by far the most common cause of Parkinsonism is Parkinson's disease. Parkinson's disease is a common disease. It affects 1% of adults over the age of 60. It's the second most prevalent neurodegenerative disease after Alzheimer's. It's slightly more common in men, as shown here. So we'll talk a lot about Parkinson's disease. And then, as I mentioned, I'm going to highlight just some of the other causes of Parkinsonism, which include secondary Parkinsonism or the atypical Parkinson's syndromes. So Parkinson's disease, this is not that important to caring for patients, but it is sometimes a board question. So I just wanted to mention it. It's an alpha-synucleinopathy, meaning that the pathology is misfolded alpha-synuclein that forms these structures called Lewy bodies. There are two other alpha-synucleinopathies that are also cause Parkinsonism. Those are dementia with Lewy bodies and multiple system atrophy. And then there are two other Parkinson's plus syndromes, progressive supranuclear palsy and cortical basal degeneration, that are actually due to tau pathology, so misfolded tau rather than alpha-synuclein. But importantly, all four of these syndromes present with Parkinsonism, so they should be on your radar when you're evaluating a patient. And if there are any red flags, you should be thinking, is this not regular old Parkinson's disease, but rather one of these rarer diseases? So just to go over briefly the diagnostic criteria for Parkinson's disease, I want to stress that Parkinson's disease is a clinical diagnosis. So there's really a very limited role for laboratory or imaging workup, although I'll mention a couple times when you would want imaging. I like to use the diagnostic criteria from the Movement Disorder Society because I think it really stresses the key features. So the main thing you need to know to diagnose Parkinson's disease is that you have to have defined a Parkinsonian syndrome like our patient had. And this is defined importantly as bradykinesia, that's the key feature of Parkinson's disease, with either rest tremor or rigidity. And I really want to stress that you only need one of those two with bradykinesia. So a question patients often say or ask is, oh, I don't think I can have Parkinson's disease because I don't have tremor. And although most people with Parkinson's have tremor, around 25% or so do not have tremor. So if you have bradykinesia and rigidity, that is sufficient to make the diagnosis. You do not need to have tremor. I also want to note that postural instability is actually not part of these newer diagnostic criteria. Postural instability is common in Parkinson's disease, but it's common with advanced Parkinson's disease. And so it's actually been removed from the diagnostic criteria because if you see postural instability or major problems with balance right off the bat, that's actually a little bit of a red flag that you might be dealing with one of the Parkinson's plus syndromes rather than regular idiopathic Parkinson's disease. We don't need to go through the rest of these criteria. I'll just highlight a few supportive criteria that can help you know that you've made the correct diagnosis of idiopathic Parkinson's disease. One is a clear, dramatic response to dopaminergic therapy. Another is presence of levodopa-induced dyskinesia. And then rest tremor, while not required for the diagnosis, if it is present, really points you towards this being idiopathic Parkinson's rather than a Parkinson's plus syndrome. You can use some tests to help you make the diagnosis, although I'll say in practice, these are not used very much in the United States. And I'll just also note that the DAT scan is not one of the tests that's considered to have enough specificity or sensitivity to make the diagnosis. So later in the lecture, I'll talk about times when you would want a DAT scan, but it's for the most part not always that helpful. This I've included only for your reference. I'm not going to read through all these. These are exclusion criteria, and these are red flags. So these are basically findings that if you were to see them, all point you away from idiopathic Parkinson's and towards a Parkinson's plus syndrome. So to briefly discuss the treatment of Parkinson's disease, the treatment for the motor symptoms of the disease mostly relies on therapies that increase dopamine. Parkinson's is fundamentally a disease of dopamine deficiency, so many of our therapies are involved in giving that back. There's also a couple of other therapies listed at the bottom of this chart, which include the anticholinergics or amantadine. And I just wanted to highlight a few clinical pearls for you here. The treatment of Parkinson's is complex and it could be a lecture in and of itself. But since this is a board review course, I wanted to highlight a few things that are sort of clinical pearls and easy questions. So of the treatments that increase dopamine, I'll start by just mentioning that carbidopa levodopa comes in two doses, 10, 100, or 25, 100. For the most part, there's really very little role for 10, 100. If you're using 10, 100, you're just using less carbidopa. And the role of carbidopa is to block the peripheral conversion of levodopa to dopamine, which causes a lot of the side effects of this medicine. So nausea, vomiting, dizziness, etc. And so, for the most part, you want more carbidopa to make sure that medicine is getting to the brain and not being converted in the periphery. I'll highlight a few other things that I think could be likely questions on a board exam. So the dopamine agonists work similarly to carbidopa, levodopa. They do have a slightly different side effect profile, which includes impulse control disorders. This can be a big deal, particularly in young people, and something that you want to screen for to make sure they're not having pathologic gambling, sexual activity, shopping, etc. The MAO-B inhibitors, this may still come up in a board type question. There's a theoretical risk for tyramine crisis. So that's why we all learned in medical school not to eat aged cheeses and salty meats and things with these drugs. I'll tell you, in practice, this is not a real thing. So this was an issue with the original non-selective MAO inhibitors, but with the MAO-B inhibitors, this is something that we really truly don't see at all, but it still sometimes comes up on the boards. And then these last two medicines, I just wanted to mention some, again, clinical advice. Anticholinergics are mostly helpful for tremor. Tremor sometimes does not respond as well to carbidopa, levodopa as some of the other movements. And so this could be a good thing to have in your pocket for people with refractory tremor. Amantadine is mostly useful for dyskinesias. I'll just mention deep brain stimulation as a treatment for more advanced Parkinson's disease. That's well beyond the scope of this lecture, but I've included some information here for your reference. And then finally, I wanted to say that it's important to recognize that although we all notice the motor symptoms of Parkinson's, there are numerous premotor and non-motor symptoms. So the premotor symptoms are things that predate the diagnosis of Parkinson's usually. There are also these non-motor symptoms that happen later in disease. And it's important to be aware of these because they actually lead to greater impairment and quality of life than the motor symptoms. And they can be more challenging to treat, but many of them are treatable. So I include them here just to highlight that this is something that should be not neglected when caring for a patient with Parkinson's disease. I've listed here a laundry list of some treatments for the various premotor and non-motor symptoms. Again, I'm not going to read this out loud, but I have included it for your reference and as a reminder that you should treat these things. So that brings us to case 2. This is a 75-year-old female who presents with 3 months of slowness and stiffness of the left arm and tremor of the left arm and leg. Her symptoms arose fairly acutely, and she actually attributed them to an experimental medicine for COPD that she was taking as part of a clinical trial. On exam, she had cogwheel rigidity at the left elbow, slow finger taps, and an intermittent resting tremor. She also had a left pronator drift, 4 out of 5 strength at the left shoulder and left wrist extension, 4 out of 5 strength with left hip flexion. And on gait exam, she had a stooped posture and reduced left arm swing. So I'm highlighting here in the second paragraph what I want to draw your attention to, which is that this woman, unlike our first patient, actually has frank left-sided weakness. And if you remember my original definition of hypokinetic movement disorders, the definition was that there had to be a paucity of voluntary movements that is not explained by weakness or spasticity. So this is an interesting case in that this woman seems to have Parkinsonism, but she also has weakness, meaning we need to think a little bit more about this before just calling this idiopathic Parkinson's disease. So for her, I actually did obtain an MRI, and what you can see is that she has a teeny little lacunar stroke here in the midbrain, and it happens to be exactly in the substantia nigra, which is where the dopaminergic neurons live. So this is actually a case of vascular Parkinsonism. And I should just say before moving on, I gave her a little bit of carbidopa, levodopa, and she did great. I followed this woman for 5 years, and she's had no progression of her symptoms. I wanted to also show you this MRI because this is a little bit more typical of vascular Parkinsonism. So there's really two types of vascular Parkinsonism. There are people who happen to have an acute stroke in exactly the wrong place, like the case I showed you, or there are people who have an MRI that looks more like this, where they have likely chronic hypertension, hyperlipidemia, diabetes, and so they have a lot of small vessel disease in the brain, and this causes subcortical damage that can indirectly cause Parkinsonism as well. This slide is basically making the same point that there are kind of two different types, and then also highlighting the fact that sometimes a vascular event can kind of unmask a neurodegenerative Parkinsonism. So it is possible to actually have both, where the vascular event was sort of the straw that broke the camel's back and woke up the Parkinson's disease, so to speak. And so this is a time in which a DAT scan actually might be helpful in making the diagnosis. So a DAT scan is shown on the right here. A normal scan is shown here on the bottom, and you can see good signal in the caudate and putamen. With idiopathic Parkinson's disease, you see a loss of that signal on the far right. If something is truly just vascular Parkinsonism, you should have a normal DAT scan, or as I mentioned, you can sometimes have this sort of mixed picture, and so this may be helpful in sorting that all out. I'm just going to mention very briefly some of the features of vascular Parkinsonism. Again, you can think about it as sort of either acute, this more insidious picture, or a mixed picture. And I wanted to highlight some features in particular of the insidious picture, and that is that there's often a lot of symptoms in the legs and a lot of postural instability. So you'll see gait freezing, legs worse than arms, early falls. These can all be clues to the fact that you have a vascular Parkinsonism picture rather than idiopathic Parkinson's disease. There can also be an absence of levodopa responsiveness. Whereas in the more acute vascular Parkinsonism, like the patient I showed you, they often are levodopa responsive. Okay, that brings me to case 3. So this is a 74-year-old woman with a history of bipolar disorder, chronic pain, seizures, who presented with tremor and cognitive impairment. Her current medications were aripiprazole, olanzapine, and gabapentin. And she had a lengthy prior medication history. This is a real patient. She had previously been on levetiracetam, phenytoin, lithium, hydromorphone, fentanyl, trazodone, lorazepam, alprazolam, fluoxetine, and metoclopramide. On exam, she had orobuccal dyskinesias. She had a tremor of her jaw, a right hand resting tremor, bilateral postural tremor, and bilateral rigidity that was worse on the right than the left. And so you can see here, again, she has some Parkinsonism with the rigidity and the rest tremor, but there's a lot of other things going on as well. She also has this postural tremor, which can happen in Parkinson's, but is not usually prominent early. And then she has this dyskinesia, which again can happen with Parkinson's in response to treatment with levodopa, but is not usually a presenting feature of the disease. So this is actually drug-induced Parkinsonism. Drug-induced Parkinsonism is one of the movement disorders that's caused by medications. You can see she was on a very lengthy list of medications, including several that can potentially cause Parkinsonism. On the right here, I just wanted to highlight that there are sort of 3 subsets of drug-induced Parkinsonism. So there are the tardive syndromes, which happen in very late. There is subacute Parkinsonism, which is what this is an example of. And then there are acute movement disorders emergencies that can happen. So I'm only talking about sort of class number 2 here, these subacute disorders. I also wanted to mention that we're actually seeing an increasing incidence of drug-induced Parkinsonism. So that's likely because of the increased use of second-generation antipsychotics, which, although they are safer than the original antipsychotics, are being prescribed very, very widely for an increasing number of indications. So more and more people with depression are getting them. And so we're actually seeing more of this than we used to. Here are just some clinical pearls about drug-induced Parkinsonism to highlight a few things that might tip you off to the diagnosis, like this patient had postural tremor and oral buccal dyskinesias. There's also a few risk factors listed here that seem to increase your risk of developing drug-induced Parkinsonism. Here I've included for your reference medications that cause drug-induced Parkinsonism. Again, I'll highlight, of course, both the typical and atypical antipsychotic drugs, and she was on an atypical antipsychotic too, in fact. Also the antiemetics, and this woman had also had a history of metoclopramide use before in the past. So those are important to keep in mind, and this is a common boards question as well. Drug-induced Parkinsonism is another time where you might consider a DAT scan if it's on your differential, although I'll just caution you that it's similar to vascular Parkinsonism in the sense that sometimes there can be sort of a mixed picture where a drug can actually unmask a neurodegenerative Parkinson's disease. Regardless, the treatment is to stop the offending agent and to monitor for at least 6 months for improvement. If somebody truly needs to be on an antipsychotic for psychiatric reasons, then we recommend clozapine or quetiapine. Those are the antipsychotics that have the least amount of movement disorders associated with them. There can be some anecdotal evidence for amantadine or anticholinergics in treating these. You can even consider giving them levodopa as if they had Parkinson's disease. It is sometimes helpful. And then just to mention again, the treatment for tardive syndromes is different and more complex. So I'm not going to go into that here. That brings me to case 4. Case 4 is a 67-year-old female who presents with recurrent falls over the last year, now occurring on a weekly basis. She's got difficulty with fine motor tasks, such as buttoning her shirt. She also reports difficulty following the movement of the ball at football games, trouble reading despite changing of her glasses. Her sister reports that she seems more withdrawn, and she has trouble managing the household finances. On exam, she has a staring expression with diminished blink frequency. She has impaired vertical saccades, and there is a mild bilateral upper and lower limb bradykinesia and rigidity without rest tremor. She has increased axial tone and a broad-based gait, and pull test is positive. So again, here we have a case where she certainly has some Parkinsonism. I've told you she has bradykinesia and rigidity, but again, there's sort of more going on here, right? So she is having constant falls despite being early in the course of her symptoms. And that is a real tip-off to the fact that this is more than idiopathic Parkinson's disease. The other tip-off is this difficulty following the movement of the ball and trouble reading with impaired vertical saccades. So this is progressive supranuclear palsy. It is one of the 4 atypical Parkinson's syndromes. And unfortunately, I don't have time to go through all 4. So I've chosen this one as the most common of the atypical Parkinson's syndromes. It's notable for symmetric Parkinsonism in contrast to idiopathic Parkinson's disease. And it's usually very axial. So you see a lot of truncal rigidity, falls, less so in the arms and legs. Usually the legs are worse than the arms. This causes early falls and impaired vertical eye movements. I've listed some other supportive features here, which I'm not going to go through at length. This is a patient of mine that I'm with progressive supranuclear palsy, and I'm going to use her to kind of highlight the eye movement abnormalities. Some helpful things to know for those of you who are, like myself, not neuro-ophthalmologists and not eye experts. Usually down gaze is impaired before up gaze, and voluntary saccades are impaired before targeted saccades, which are in turn impaired before pursuit. And so I'll explain what I mean by that here in the video.
Okay, so what I want you to do is just look all the way up for me without moving your head, just with your eyes. Okay, and then look all the way down.
So I'm asking her to look down and then
all
up.
the way up.
And you can see her eyes
All the
are
way
very
down.
slow.
Okay, and now I want you to look all the way to the left.
When she looks to the left, they're also
and then all the way
slow.
to the right.
And to the right, although a little less so than
And
vertically.
now, what I'm going to have you do is I'm actually going to put my finger out here, and I want you to look at my finger, and I want you to just follow it with your eyes without moving your head. So follow my finger.
So now I'm testing pursuit, and you can see that in contrast to her voluntary saccades, pursuit is much better. The eyes are much faster.
And down.
Not perfect, but much faster.
Okay, and now what I want you to do We didn't do this part earlier, but I want you to look at my nose here. And then when I tell you to, I want you to look at my thumb over here.
So these are
So
targeted
look at my
saccades.
thumb.
And
Look
again,
at my
targeted
nose.
saccades where I've asked her
Look
to
at my
go
thumb.
from my nose to my
Okay, now I'm
thumb
going to do the same thing on the other side.
much
So look at my
faster.
thumb, nose, thumb, nose.
Again,
Okay.
still not normal, but much
Very
faster.
good.
Okay, we can stop that there. And so again, that just really highlights that it's important to ask patients to do voluntary saccades. So she's most impaired when I simply ask her to look up or down. Okay. A couple of imaging findings in PSP that can be common board questions. There is the hummingbird sign and the Mickey Mouse sign. This is because PSP causes atrophy of the midbrain and the brainstem. And so you see a very full pons here in the middle of the brainstem with a very small midbrain, so it looks like a hummingbird. And then shown in axial sections, likewise, the midbrain atrophy. Instead of a nice plump midbrain here, due to all the atrophy here, it looks like Mickey Mouse ears. Okay, that brings me to case 5. This is a 50-year-old male who complains of tremor in his hands. It's causing difficulty with writing and eating. It's worse with anxiety and improves with alcohol. He takes no medications. His brother and mother have a similar tremor. On exam, he has a postural and kinetic tremor. He's unable to hold a cup of water in the office without spilling it, and there is no rest tremor. His gait is normal. So we're now moving into the hyperkinetic movement disorders, starting with tremor. So before I talk to you about this patient in detail, and he has essential tremor, I wanted to take a step back and give you some general points about tremor. So the first thing I do when I see a patient for tremor is I take a step back and say, is it tremor? And the reason that I do that is because many hyperkinetic movements are described by patients as shaking or tremor. So the first thing is to figure out if that really is the movement that you're seeing. Tremor is defined as an involuntary, rhythmic, oscillatory movement. And so you need to make sure that it does seem to have those features. And then I wanted to take you through a little bit of the terminology of that we use around tremor, because I find that these terms are often used incorrectly. So my approach to tremor is to start first by dividing it into action versus rest. So we've already heard a lot about rest tremor, which is usually due to Parkinson's. A rest tremor occurs, obviously, when the patient is at rest, and also importantly, not thinking about the tremor. And I add that in because most people with rest tremor are able to suppress it if they think about it. In contrast, an action tremor is basically any other tremor. So an action tremor is a tremor that occurs with an action, which can be a movement, a specific task, or even holding a posture is considered an action. A kinetic tremor is a tremor that occurs with movement. A postural tremor is a tremor that occurs while maintaining a specific posture. And then I wanted to draw your attention to the term intention tremor, because I see this term used incorrectly quite often. So an intention tremor is a very specific type of action tremor that you detect when asking the patient to do finger, nose, finger testing. And the key with an intention tremor is that the tremor is not present throughout the movement, but only when you get to the very, very end of the target. And so when you say intention tremor, this really implies that the tremor is of cerebellar origin. So it's actually a very specific finding. So you should not refer to any old kinetic tremor as intention tremor unless truly it only shows up at the very end of the goal-directed movement. So this is my approach to tremor. I think the first step should be to characterize what is the main feature of the tremor, recognizing that many tremors have components in different categories. If you start with figuring out what the main feature is, whether it's kinetic, postural, or rest, this can point you fairly quickly towards the most common etiologies of tremor, and then you can direct the rest of your thinking towards trying to confirm one of these diagnoses. So this case that I gave you, this is a case of essential tremor. Essential tremor is the most common cause of tremor and the most common movement disorder. It's a fairly common disorder. It usually begins in the hands and then progresses to the head. We call it a yes tremor, meaning that people typically have a tremor that nods their head up and down as if they're saying yes. That's in contrast to a dystonic head tremor, which is often a no side to side tremor. It's usually pretty symmetric. It's an action tremor that's usually kinetic more than postural at onset, although there can eventually be a big postural component. There's usually a family history, and it usually improves with alcohol, just like in our patient. I would caution you that many types of tremor improve with alcohol because most types of tremor are worse with stress. And so, alcohol as an anxiolytic can actually improve quite a lot of kinds of tremor. I'm going to show you a video here of a patient with essential tremor similar to the one that I described. So you can see he clearly has a postural and action tremor, and his is fairly severe. He's not able to keep water in the cup, just like we heard about with our patient. And so this is a helpful test that you can do in the office. Okay, so to go over briefly the treatment for essential tremor, there are two first-line agents. Those are propranolol and primidone. There are several second-line agents that I've listed there. The latest evidence is that levetiracetam and pregabalin are likely not efficacious. And for people that have refractory tremor, there are also surgical options that I just wanted to mention. But again, to reiterate, the first-line agents are propranolol and primidone. They both have some side effects. Propranolol, of course, can lower your blood pressure and heart rate. Primidone can cause sedation. This is for your reference, highlighting some of the differences between essential tremor versus a Parkinsonian tremor. In theory, if you read a textbook, it sounds like these two diseases are always incredibly easy to distinguish. In practice, sometimes there's more overlap than you would think. So this chart is here to kind of highlight some of the differences. And then also, I'll just mention this is another time in which a DAT scan could possibly be helpful if you're not sure if it's essential tremor versus a Parkinson's tremor. Okay, so case six. Case six is a 31-year-old female. She developed bilateral hand action tremors. She has a history of anxiety and depression. On exam, she had a 1 to 3 centimeter postural and kinetic hand tremor bilaterally, and it was variable and distractible. For diagnostics, she has had a normal MRI brain and a negative DAT scan. So this is a case of psychogenic tremor, and so I'll tell you a little bit about psychogenic Parkinsonism and tremor. I will say that full psychogenic Parkinsonism is not very common, but psychogenic tremor is actually quite common. We see it quite a lot in the movement disorders office. These are some features that could point you towards a psychogenic diagnosis. The four that I want to highlight in terms of tremor specifically are entrainability, distractibility, variability, and suggestibility. And I will show you videos of each one of those. So this is an example of distractibility. You'll see in this video that this woman is going to be asked to recite months of the year backwards, and her tremor changes in character a whole lot.
December, November, October.
So it sort of stops for a minute there. The amplitude changes.
August, September.
Now the whole nature of the movement has changed. The fingers are more involved. It stops there again. So this is all a key to the diagnosis of psychogenic tremor. Here, this woman, you're going to see the feature of variability. So her tremor frequency and amplitude and even the limbs that are involved actually change throughout the video. So it starts in both hands and the left leg. Here it becomes sort of a rotatory movement instead of an up and down movement, and then goes back to more up and down. Also see some distractibility there with the finger, nose, finger. Now she's changed the entire nature of the movement, and now suddenly the right leg is involved. So this really highlights the extreme variability in the tremor. So that's a clue to the diagnosis here. This is highlighting suggestibility. So this patient has been told that if you put a vibrating tuning fork on him, the tremor might get worse. There's no physiologic basis for that. So this is to demonstrate suggestibility. And indeed, with the tuning fork, his tremor does get much worse. Okay, and then finally, this video also shows variability and then entrainability. So she has this sort of truncal rocking motion as well as tremor in the right arm. Here she's been asked to open and close her hand, and you can actually see that the truncal rocking entrains to the exact same rhythm as the hand opening and closing. So that's the clue here to the diagnosis of psychogenic tremor. And I'll just conclude saying these videos are not meant to be funny. This is a real problem that people are not, they're not faking. They're not doing this consciously in any way. This is an unconscious pathology of the brain, and people can actually really suffer from these symptoms. So the treatment for this is really cognitive behavioral therapy, referral to a neurologist, and a psychotherapist. So that brings us to case 7. So this is an 83-year-old female who presents with 18 months of abnormal movements involving the hands and feet. She's developed irritability and inappropriate jocularity. Her parents died in their 50s of cardiac disease. On exam, she has chorea involving the upper face in addition to the arms and legs. She also demonstrates impulsivity, including making inappropriate jokes. Her laboratory workup is negative, and CT of the brain shows bilateral moderate caudate atrophy. So this here is a case of chorea. The differential diagnosis of chorea is very, very long. This in particular is a case of Huntington's disease, which I've chosen Huntington's disease because although it's a very rare disease, it is a very beloved board question, so it's possible that it would come up. One of the imaging features that's a key to the diagnosis is the caudate atrophy, shown here. And then I'll show you a video of a woman with Huntington's disease so you can see what the chorea looks like. So you see chorea is described as these sort of writhing dance-like movements. You can see that in her arms, her legs. Eventually we'll also see it in her face, more zoomed in. So there's some chorea around her mouth as well as her eyes and her whole head, really. So this is pretty severe involvement. One of the things you can see is motor impersistence. So if people are asked to put their tongue out, they have a hard time continuing to do it. You can also see this milkmaid's grip where they're sort of squeezing and letting go. Okay. So the diagnosis of chorea is actually incredibly complicated, so I will just leave you with a few thoughts. It can be helpful to try to localize where the chorea is. So if there's forehead chorea, as in this patient, that can be a tip-off to Huntington's disease. If there's oral buccal chorea, that is often a tardive syndrome, like we saw with the earlier patient with drug-induced Parkinsonism. And if there's hemichorea, that often points to a structural lesion. Here's a flow chart for going through causes of chorea. But again, I would just stress that the list of differential diagnoses here is very, very long. So I think as an internist, the key would be to recognize that the movement is chorea and then refer to a neurologist. These are the treatments for chorea for your reference. The main two are these, they're dopamine depleters, so tetrabenazine and reserpine, and they're now newer generation VMAT2 inhibitors, deutetrabenazine and valbenazine, that work a little bit better. If those don't work, you can also use antipsychotics. Okay, so we're down to the last few cases, again, just to highlight the different hyperkinetic movement disorders. So case 8 is a 57-year-old male who presents with left arm jerking. These jerks happen randomly and last a few seconds. Recently, they've increased in frequency. There's no family history of similar symptoms, and he takes no medications. On exam in the office, he had a witness spell in which his left arm repeatedly jerked at the frequency of 1 jerk per second, lasting a few seconds. He was alert throughout the episode. A routine EEG was normal, but then he was admitted for continuous EEG, which demonstrated sharply contoured theta over the right central head region. This is a fancy neurology way of saying epilepsy. So the diagnosis was myoclonic focal seizures, and he was treated with carbamazepine. So this is a case of epileptic myoclonus. I'll tell you a little bit about myoclonus, and then I'd like to show you a video. So myoclonus is defined as these very brief, lightning fast muscle contractions. It's important to recognize that myoclonus is a sign, not a diagnosis. The differential diagnosis is long. Some things that are helpful in evaluation are a medication history. Many medications cause myoclonus. Also basic laboratory workups. So liver or renal failure can cause myoclonus. A drug and tox screen can be helpful. An EEG is probably the most helpful test, as in this case, because really you want to rule out epileptic myoclonus. An MRI can be helpful in looking for a structural lesion. There's lots of ways to classify myoclonus. So you can classify it by localization. Any part of the nervous system can cause myoclonus. I find in practice this is not that helpful because it doesn't really tell you that much about what the underlying diagnosis is or how to treat it. More helpful, I find, is to classify it by etiology. So there's physiologic myoclonus. An example of that is hypnic jerks, which is what happens to many of us when we're falling asleep at night, where you feel like the bed went out from under you and your whole body jerks. That's totally normal. Essential myoclonus refers to myoclonus in which it's basically the only or nearly the only symptom. Usually there's a genetic explanation for this and it's not progressive. Epileptic myoclonus, like this patient had, can be part of an epilepsy syndrome. So there can be either juvenile myoclonic epilepsy or focal seizures. And there you're going to really want to get imaging to look for a structural lesion. And or it can be symptomatic, secondary to another medical or neurologic illness. And again, there's just a very extensive differential diagnosis there. So this is an example of myoclonus. And in this particular case, this patient actually has focal myoclonus due to PML, which is not what our patient had. He just had focal seizures. But it shows you what myoclonus looks like. So again, the key is these very, very fast movements. He's got, and small amplitude movements. So you can see those fast, jerky movements of the left hand there. There are moments where it sort of looks like tremor, but it's more irregular than tremor. And the posture would not be typical for tremor either. Okay, so that gives you a good idea. There you see more of what we know, typical myoclonus with the lightning quick jerk. Okay, so this brings us to case 9. Case 9 is a 59-year-old male who presents with 5 years of progressive gait disturbance. He has a sister with similar symptoms. On exam, he has a wide-based gait with variable step length. He's unable to tandem walk, and there is dysmetria with finger-nose finger testing and heel-to-shin testing. His MRI demonstrates cerebellar atrophy. After genetic testing, he's diagnosed with spinocerebellar ataxia type 3 and treated with riluzole. So the goal of this case is not that you understand spinocerebellar ataxia 3, one of the numerous genetic etiologies of ataxia, but rather that you understand just what ataxia is so that you can recognize it. So basically, ataxia causes variability in stride length or rate and variability in step width. That's shown here at the top. Early ataxia is usually noticed as an inability to tandem walk. As it becomes more advanced, patients have a notably wide gait. Patients will often describe it like, oh, I look like I'm drunk, or I feel like I'm on a boat, and they can sometimes veer to one side. I'm going to show you this video that show different degrees of gait ataxia. So starting from early ataxia and moving towards a more marked ataxia. And again, the individual diagnoses here are not that important. There are numerous causes of ataxia, both genetic and acquired.
Okay, come back.
So this patient has a little difficulty with the turn. He kind of veers to the right.
Okay, stop right there.
But it's fairly subtle. His gait's still narrow. Now we'll see a more moderate ataxia. So here he has a wide stance. He's a little bit slow. He's got his arms braced for additional postural support. Slow turn and very wide on the turn. And now we'll see a severe ataxia. So very wide stance here. Again, arms out for support. She has to actually grab the wall in order to turn. So that gives you a sense of what an ataxic gait looks like. And again, I would just focus on recognizing that motion and then referring to neurology because the list of differential diagnoses is quite long. So this brings me to case 10. This is the 55-year-old, or sorry, excuse me, 45-year-old male presents with pain in his neck. He had a normal C-spine MRI. Touching the side of his face relieves this pain. An exam reveals head turn to the left and a left head tilt. This is a case of cervical dystonia, and he was treated with botulinum toxin. I'll show you a video here of what cervical dystonia looks like. Okay, so this is a patient with cervical dystonia. She happens to have a rare genetic etiology as the cause for cervical dystonia, but I'm using, but I'm using the video just to highlight what cervical dystonia looks like. So we'll see here in a second. He has a very notable head tilt to the left as well as a head turn to the right. So the head here wants to be in a position other than the midline. This is not voluntary. It's usually fairly uncomfortable. Often you'll see people sort of grimacing like he is. And you can even see hypertrophy of the sternocleidomastoid from having to maintain that position so frequently. Sometimes walking can bring out a dystonia. And so for this, again, you see really prominent head tilt as well as turn. To take you through our approach to dystonia, dystonia is a movement disorder defined by sustained or intermittent muscle contractions, which causes abnormal, often repetitive movements, postures, or both. One thing that can be helpful to the diagnosis is a gest antagonist. That's also known as a sensory trick. So in this case, the patient who touches the side of his face is actually able to relieve the dystonia. That's a very common sensory trick for cervical dystonia, and many people find it helpful. It's sort of a way of tricking the brain out of doing the movement. The most common dystonia by far is just idiopathic cervical dystonia. So that's a focal dystonia. And whenever you see a focal dystonia that emerges after the age of 40, such as cervical dystonia, writer's cramp, or musician's dystonia, you really don't need any additional workup. This is a common idiopathic movement disorder. For pretty much anything else, onset before 40 or anything other than a focal dystonia, you really need a genetic workup. And here you're going to want to involve, for sure, a neurologist as well as a medical geneticist, because there is an extremely long list of genetic causes of dystonia. New genes are emerging, it seems like every day. For focal dystonia such as this, botulinum toxin is really the treatment of choice. If for some reason patients do not want botulinum toxin or they have some other contraindication, you can consider pharmacologic therapy with oral medicines that I've included here for your reference. But I will just again stress that, that really botulinum toxin is preferable to these. All of these have side effects and are less effective. Okay, case 11. This is a 19-year-old man who presents with shoulder shrugging movements that happen many times per day. He feels an urge to move his shoulders and then feels better after doing so. He can stop the movements if he tries hard. He has a history of ADHD and recently started amphetamine, dextroamphetamine for this. At age 7, he developed eye blinking and throat clearing sounds. These were worse with stress, and they improved when he hit his adolescence. On his exam, he has shoulder shrugging as well as makes occasional clicking sounds. So this is a case of Tourette syndrome. The treatment is a specific type of cognitive behavioral therapy called comprehensive behavioral intervention for tics, and he's also started on guanfacine. And I highlighted this case. You think of Tourette syndrome as a childhood disease, but this is actually not very unusual for people to present in early adulthood. Often they've gone undiagnosed as children because they had tics for some period of time that then improved during adolescence, like this patient's did. That's very typical. And then they can often reemerge in early adulthood, particularly in the setting of treatment for the psychiatric comorbidities of Tourette syndrome. So stimulants such as this do not cause tics, but they can kind of bring out the tics. So this is a real patient who showed up at age 19 with previously undiagnosed Tourette syndrome. So just to tell you a little bit more about tics, tics are hyperkinetic movements. There's usually a precipitating factor. There can be a waxing and waning pattern, and there is often a premonitory urge. So people feel this need to do the motion, and then they feel relief when they've done the motion. They can be suppressible, at least for a period of time, although that is challenging and stressful to the patients to suppress them. Most individuals with Tourette syndrome have at least one neuropsychiatric comorbidity. There's a very common association with ADHD, OCD, and also anxiety and depression. The treatment of tics is education and behavioral therapy, as was the case for this patient. And then there are quite a variety of pharmacologic options that I've shown here. The tier 1 medications include guanfacine, clonidine, topiramate, clonazepam, and baclofen. So that's why this patient was trialed on guanfacine, because he was treatment naive. All of these medicines have a variety of side effects. So if people fail the tier 1 medicines, often due to side effects, then you can consider these tier 2 medicines. So this is just for your reference. So that concludes all of the cases. I've shown you here the diagnosis of each case. But again, driving home the point that at least for the hyperkinetic movement disorders, I think the exact diagnosis is less important than being able to recognize the movement. So now we'll just finish the talk with 3 board questions. Question 1, a 55-year-old woman is evaluated for a 1-year history of tremor. The tremor affects both arms and is symmetric. She has type 2 diabetes, hypertension, and chronic kidney disease. Medicines include insulin, lisinopril, and metoclopramide. On exam, she has masked facies, slow movements, and mild bilateral symmetric rigidity in the arms and legs. There is a symmetric resting as well as postural tremor in both arms. What is the most likely diagnosis? A, progressive supranuclear palsy, B, essential tremor, C, Parkinson's disease, D, drug-induced Parkinsonism, or E, multiple system atrophy. Okay, the answer to this question is drug-induced Parkinsonism. And there are several reasons for this. There are no red flags in the history to support a diagnosis of a Parkinson's plus syndrome, such as progressive supranuclear palsy or multiple system atrophy. So she's not having early falls or ataxia or anything like that. Then on her exam, she has Parkinsonism, which means you can't make a simple diagnosis of essential tremor, even though she has tremor as part of the exam. Parkinson's disease would definitely be a consideration, but the things that point you away from Parkinson's and toward drug-induced Parkinsonism are the fact that she has a postural tremor. It's very symmetric at onset, as opposed to idiopathic Parkinson's, which is usually asymmetric at onset. And then she has this history of metoclopramide usage, a classic board's question favorite that can cause drug-induced Parkinsonism. So the treatment for her should be to stop the metoclopramide, and then she should be monitored for at least 6 months for improvement. If for some reason she wasn't improving, you would consider whether this could be a slightly atypical presentation of Parkinson's disease, and you might consider getting a DAT scan. So question 2, a 62-year-old woman presents with 10 years of tremor in both arms. Her handwriting is terrible. She cannot hold a cup of coffee without spilling it. She's afraid she has Parkinson's disease. On exam, she has a mild tremor present with arms extended and during finger to nose testing. There's no resting tremor and her tone is normal. What is the most appropriate treatment for her tremor? A, propranolol, B, carbidopa-levodopa, C, gabapentin, D, topiramate, or E, ropinirole. So the answer here is propranolol. So this is a case of essential tremor. You know that because she does not have any evidence of Parkinsonism, so her tone is normal and there's no mention of bradykinesia. She has a postural and action tremor that's long-standing. So all of that tells you this is essential tremor. Of the options listed, only propranolol is a first-line agent. As a reminder, the other first-line agent for essential tremor is primidone. Topiramate and gabapentin are second-line agents, so those would be considerations if she were to fail a first-line agent. And then carbidopa-levodopa and ropinirole are treatments for Parkinson's disease, so not appropriate for this case. Okay, and the final question, question 3. This is a 57-year-old male with Parkinson's disease. He's brought to clinic by his wife, who is concerned about his behavior. He's been spending increasing amounts of time at a casino. She also notes that he has increased libido and is frequently sexting her, which he never did before. His medications are carbidopa, levodopa, 25-100, 3 times a day, and ropinirole, 1 mg, 3 times a day. On exam, he has mild rigidity and resting tremor on the left greater than right. So what is the best management option here? A, decreases carbidopa, levodopa. B, increases carbidopa, levodopa. C, discontinue ropinirole immediately. Or D, decrease ropinirole gradually. Okay, so the answer is decrease ropinirole gradually. And I made this case a little bit, or this question a little bit challenging because there's 2 issues that I want you to actually recognize here. So the first is what's going on here is that this is impulse control disorder related to a dopamine agonist, ropinirole use. This is actually a patient of mine. This is a real patient that I saw who developed problems with sexting, a problem of our modern world. So this is due to ropinirole. It definitely does need to be discontinued. But the other issue that I wanted to highlight is that actually abruptly stopping a dopamine agonist can cause a severe withdrawal syndrome. So it has to be stopped gradually over a period of a few weeks. He may then ultimately need increased carbidopa, levodopa to make up for the decreased ropinirole, as his motor symptoms are likely to get worse. But this is not the first step, because right now his Parkinsonism is well controlled and he's having these behavioral problems. So that concludes my talk. I have 2 slides of references here just for your information if you're interested in learning more about movement disorders. And I hope that the talk was useful.